All right, we can go ahead and get started. Hey everyone, my name is Cheyenne. If you don't already know me, thank you so much for being here on a Sunday afternoon to learn more about different physician specialties. Before we get started and talk to Dr. Poornema Ramasamy, I'd like to share the kind of bigger initiative that this is part of. I'm going to drop a link in the chat. You could also see it on my screen. But this is part of a project called PhysiLink. But basically, the idea is that each month we'll have a doctor that will be featured on this website, and you could interact with them by asking them questions. You could submit questions here, and then at the end of the month, they're going to answer their question, and you'll be able to see it. So Dr. Fernandez is the physician from October, and then right after this webinar, we'll update it with Dr. Poornima Ramasamy. But you will be able to see all the previous doctors and be able to go back and visit the questions. And then the recording of this webinar will also be posted, which you could access with this tab. Um, and then if you want to be in the loop, you could join our newsletter. And then every month when we get a new doctor, a recording goes up or a question is answered, we will post our answers, or we'll post an email with all that information. So I will once again drop it in the chat. If you have any questions about that, feel free to ask me afterwards. All right, so let's start with Dr. Ramasamy. Would you mind giving us a general introduction on your education background and what you do now?
Hi, Shyam. Thanks for having me here today, and good afternoon, everyone. It's nice that the it's a Sunday and it's a little bit chilly, but I think you guys are motivated enough to join us to be in this program. And thank you for having me, and I'm glad to be here to share my experience. So, about my education background, I uh, I was born and brought up in India, in South India to be exact, um, where the education system is a little different from what we go through here. After 12th grade, you go right into med school or engineering, whatever it is. So there's no undergrad for us. So I started my med school. I did my education in a small town called Rasipuram. And then from there, I went to med school to one of the big cities, Chennai, and that it, our medical school is 5.5 years. So it's like 4.5 years of theory and clinical rotation, and then 1 year of internship. So that's called CRRI. So it's a 1 year of internship, just like AI here. We get that where we rotate through different rotations and do hands-on work, and then we graduate. So after MBBS, I worked in India for a couple of years and then came here for my residency in 2003, where I joined here in Prisma Health, which used to be Palmetto Health, internal medicine program, and I did that for 3 years. And then I did my work as a hospitalist. Then I went back to do MBA, so which is another branch of I want to do some entrepreneurship and like do some startup in India in healthcare. So I did that from 2012 to 2016. So then while I was working as hospitalist, I got an opportunity to see a lot of wounds, and I got interested in that. And then the wound care center opened up, and I went on to do wound care in the center. Then I felt that I need more knowledge in that, so I went on to do certificate in that and also hyperbaric. So then I did my boards with the American Board Wound Management. So that's my education background. Here I am. I'm full-time wound care specialist now.
That's great. So we're gonna definitely jump into a lot of what you mentioned, the MBA and then the different certifications. and boards that you got. But before we go into that, so you went from an internist to hospitalist to wound care specialist. Would you mind explaining what each of those specialties are and if it's common to jump from one to the other, or is that like a pretty standard pathway?
So internal medicine is a specialty purely medical. So you're not, I mean, you do have some procedures as internal medicine. So internal medicine is broad where you get deeper knowledge. I want to say that because there's also family medicine. So there is a so family medicine program has a little bit of training in surgeries as well. Say they do like OBGYN, they take care of pediatric patients. They are surgical, but internal medicine completely deals with just adult patients. And then we dig deep into all the systems in depth. We get a little bit more critical care training. So overall, like we just take care of adult patients and their problems. So it does involve like procedures. So we do like in ICU procedures like central line starting or ventilator management, different types of lines, uh, like spinal fluid analysis, like you put a spinal tap, do a spinal tap, put a thoracostomy tube. So things like that, like we have bigger procedures as well. So there are some people who specialize to become proceduralists as well in internal medicine. So that's a subsect, like they just go on to do procedures. And then there is one group of people after they graduate, they said, oh, okay, I just want to stay in the hospital. I like the pace of the hospital. I want to take care of patients who are admitted in the hospital. So they go on to become hospitalists, like which is what I did. And then there is some set of internists that would go on to say, I don't want to deal with any hospital. I want like continuity of care. I want to see a set of patients in the outpatient world, take care of their diabetes, high blood pressure, and other problems. So they have their own clinic and then they start their own practice. Like they join a practice and then they do that. So these are different branches. And then there are some people who do both. Like I want to be hospitalist and I want to do clinical. And some of they just leave out everything and then go on to do IT, or they subspecialize into different subspecialties like cardiology, hematology, or neurology. Or neurology is a specialty by itself, but they can become that too. So several subspecialty offerings after internal medicine. Some people go on to management, like which I didn't want to go into the hospital management, but I wanted to do an entrepreneur, and that was the reason why I went on to do MBA. Some of us go on to public health policy, so they do MPH, and then they go on to do that. Did I answer your question, Shyam?
Yes. So would you say internal medicine is kind of a very broad specialty if you're not really sure what you want to do, and then you kind of do that as your specialty? Is that a 3 year residency?
Right. So I would not say that it is a broad specialty for those who did not know what to do, because right from my third year of med school, I wanted to be an internist. The idea of internal medicine fascinated me because it was like a puzzle. Like when I see a patient, I think of them as a puzzle. You don't see anything, right? Like you don't see visibly any organs from outside. A surgeon can open and see what's going on in that organ. But as an internist, a person has to have the knowledge of understanding everything just from clues from outside, looking at the body, looking at the labs and imaging. So you're just putting pieces of puzzles together and then having a diagnosis. So that just fascinated me. And that is the reason I went on to do internal medicine. And
So it gives you a more
that
broad understanding rather than kind of a narrow specialty understanding.
exactly. So
Okay.
yeah, so you would have knowledge about human body as an adult as a whole, and then you can, if you want to subspecialize, I'll go on and like fine tune yourself to do more things. You can, or you just stay like this. and then be fascinated like I am.
So then to go on to hospitalist and wound care specialist, do you take additional or even an internist that does procedural stuff? Would is that something that you do an additional certificate for or training program for? Or can you
Not
just jump
necessarily.
right into that?
Right. So for proceduralists, actually, they don't have to, like, some people just like procedures. So when they are internal resident, they would just like get more and more done. And then when they are confident, they just say like, hey, I want to be a proceduralist. So they just go on to become that. Not all hospitals offer that position, just for your information. Uh, so there are some who are like maybe like bigger centers that have lots of uh, beds in the hospital, and they may want like additional support, like proceduralists, where the regular doctors cannot afford to spend time away doing procedure. Um, so it's a little bit of our own. Yeah, it has a niche, and then it may not be like widely available, that kind of job. Whereas wound care, anybody trained as internist technically can do wound care, but I would strongly suggest that somebody goes through certificate process. There are like wound care courses that are available, and then you can, once you have a certificate, your clinical skill improves, and that is important for you and the patient. So I would highly encourage doing that. And now it's an evolving field, so there are more things that are being offered. There are like fellowships in this field as well. So there are only a handful that is across the country, and they're not ACGME recognized, but they're still there.
Gotcha. So now going into wound care specialty, what does a typical patient load look like, or what are the cases that you see, and what are the kind of some of the interest or personality traits in a person that you would like to see in wound care specialty, or what kind of people are interested in wound care specialty?
I think those who like procedures are okay. First of all, those who don't get grossed out with wounds. That's definitely the important trait to have. A lot of my friends in internal medicine, they're like, oh, I don't want to, I'm happy that you're taking care of it. I don't want to deal with wounds, and thank you very much. So they don't want to see any wounds. So I think you should have that inclination to look at the wounds and not get grossed out. And, just for me, I think I saw a lot of patients in the hospital that ended up with wounds because their back was neglected when they're laying down in the hospital. A lot of times they get neglected. The nurses are supposed to look at that, and then they would, but they won't necessarily communicate with the doctor about the presence of wound unless like a doc looks for all the nursing charts, like what they have mentioned. There's a very good chance that wound can be missed. So the skin exam is so important. So that part of thing physicians should have inclination. Number two is procedures. Like these wounds need a lot of procedures. They would have to do debridement. So if you're interested in doing like, you're comfortable with using your equipments, surgical tools, then that's for them. So I love procedures. So I just, and naturally, like wound care specialty is for surgeons, like vascular surgeons or surgeons in general go into this. So internal medicine, only a few would go into this specialty. But for me, I liked the knowledge of having the broader understanding of all the diseases, and then how a wound can be manifested in different conditions. So that is why I got into this.
So when I first thought of wound care specialist, my first thought was acute injury and like gunshot wounds and that kind of thing. That's not primarily your focus, right? It's more chronic wounds from diabetes patients.
Right. So the wound care in general, like the wound care specialists deal with um, chronic wounds. So wounds normally supposed to heal within like a couple of weeks, a week or two. That's the most. If they don't heal by third or fourth week, that's when it enters a chronic wound stage. So that is when there is a problem with the wound healing. And that's where a wound care specialists come into play. Acute wounds usually go into emergency room, and if it's trauma related, then they just are addressed in the hospital appropriately, and then they go on to surgical totally. But then the wounds that don't heal, even with that, like in acute stage, they when they reach a point of non-healing, that's when they come to us.
And this isn't just something you put a bandage over. Can you kind of walk us through like what the process is behind or what you a typical wound looks like and what you kind of do and what debridement is, which you mentioned those also.
Okay, sure. So wound care, so the wound, when a wound reaches a chronic stage of non-healing, that is obviously not normal. So we want to figure out why it's not healing. So most of the time it's diabetics, like you mentioned. Like there is a reason, like diabetics have circulation issues, nerve issues. So they don't get enough oxygenation and nutrition into the wound, and that delays the wound healing. So that is one reason. And then there are patients with high blood pressure whose blood vessels get damaged because of the blood pressure issues, and they end up with poor wound healing. People who have edema, which is like swelling in their legs from anything like heart issues or kidney issues or liver issues or just obesity. So there might be some problems with their veins in their legs. So they end up with poor healing. So there are multiple factors in wound healing. So you identify these things and then try to fix it. So the way fixing, meaning like if it's a diabetes related wound, and the most important thing is to control the sugars, because sugars put your blood cells in a coma. Because we always talk about sugar high, right? Like you when you eat, you get a high, and then after lunch, everybody want to go into this lull period where we want to sleep, right? So that's what happens to our white blood cells. The immune cells don't want to work; they are in a coma. So we want to make them work. So want to control their sugars. Um, so you want to improve oxygenation to the wound or nutrition to the wound, and that's where the debridement comes into play. So where like you scrape off all the dead cells and then wake up you are waking the cells up on the wound bed and say, hey, come on, enough sleeping, get up and like do your work of healing. So that is a reason for debridement. Debridement is basically using your tools and cleaning up, like scraping off the wound bed and scraping off the edges to get rid of all the bad dead tissue that is present on the wound. So when what we do is basically try to understand what the problem is and then address the cause of the wound. And if there is an issue with blood pressure, like if it's an issue with edema, then control the swelling and so forth. So identifying the problem and fixing it in addition to cleaning the wound, debriding the wound, and choosing the right dressing for the wound to heal, like giving an appropriate environment for the wound to heal. So that's what we do.
What are some common challenges that you face with this? And is there a component of this where the patients have to play their part in their own wound healing process? And what are some challenges that you deal with that as well?
This is like best question. I think and that is what I was going to do with my case. I'm going to case series, or I just have a couple of cases, but for wounds to heal, it's absolutely important for participation from patients. It's not going to heal unless like you have patient participation. So it's not like no matter what I do, like I clean the wound and debride the wound, I put the right dressing, and then like keep talking about like, hey, you have to control your sugars 100 times, like, unless the patient participates and gets it, yes ma'am, I'll do it, and then like do the change the dressing like I explained to them, and do the things they are supposed to do, eat the right things, controlling their sugars. If I'm asking them to exercise, do that. Like if they don't do all that, then it's not going to heal. Like no matter what I do. And there could be like, there could be the same wound with, family support, patient support. There's no support or cooperation from patient. This will lose their foot, or they would end up with amputation or complications from the wound where this one will go on to heal. So one big factor is like patient participation.
Would you say that's kind of the biggest challenge within your specialty?
Yes.
Okay.
Yes, that's the biggest challenge, especially when I think it also depends on where you serve. Like the 29203 is the zip code that I am part of. So that's like a biggest, it's one of the highest, that's a zip code for highest amputation rates in the deep south. So there is a reason for that. So we have challenging patients who have like several barriers um, that are preventing to have appropriate healing.
Gotcha. So now kind of moving on to how your schedule is. A lot of students, when they're thinking about different specialties, they kind of think about the work-life balance and the typical schedule of a specialty. So what does your schedule look like, and are you able to achieve the work-life balance that people talk about?
So as a physician, it's a really challenging. Um, it's really challenging to strike that balance. I don't know. I think if there is somebody that has told you that they have the best work-life balance as a physician, Shyam, please show them to me. You have met a lot of doctors. So I would I would be happy to sit with them and talk and get some classes. Um, However, having said that, I work only for 1.5 days. Um, I think the minimum work I have to do in order for me to get healthcare benefits was like it was zero point 0.4 FTE. So I'm doing the minimum zero point 0.4 with zero point 0.3 is for my clinical work and zero point 0.1 is for teaching. So I do that so that I will be able to get that minimum. So I wanted it that way. I wanted to have family time. I wanted to have community work time. And I wanted the ability to go to India and see my parents whenever I want to. So those were the reasons I chose to be what I am now as a part-timer. So I think if of all the people you have talked to, I probably have the work-life balance the best. Uh, but aside from the work spot, like the 1.5 days I work, things that I have to deal with are like, charting. Like I still have some pending charts, which I would have to take care of after this meeting before I jump into my clinic tomorrow. So yeah, that is that. I also would have to pre-chart some of the patients that I'll be seeing tomorrow. So I'll have to do that. So I'll have some time allotted to that. And as a physician, you are never off. You'll always have consults from family, friends, like, every single day there will be a consult in WhatsApp or messages or a phone call. So, or email. So you would always have those things, and it's not just like answering a text. It's not as simple as that, because you have to use your expert knowledge and then give them opinion. So or at least tell them that you are not the expert, and then you are trying to connect them with the right person. So all those things will actually take time. So those are so you have to remember that. And continuing medical education. So you have to keep up with the knowledge. Like, it's just like expanding like crazy. So you have to keep up with knowledge. So those are the things that you will be doing in your days off. You'll be constantly, learning things. So in spite of all that, I'm going to say that, yeah, I love what I do. I think that there is a reason why people come into medicine. And there is a good chance of getting burnt out. But you have to recognize that ahead of time, and then, do things in place, put things in place, um, so that you don't go into that hole.
But just to clarify, you said you work 1.5 days, is that on per week? But then there's a lot more work of pre-charting and charting and then answering messages and following up patients and also kind of learning as you go. And then you also mentioned, I think you said FTEs. What is that, or how does that work?
Full-time equivalent. So 1.0 is full FTE, is considered as a person who is working 40 hours a week, right? Like, that's typically what we call as full-time work. So 8 hours per day, 40 hours a week, that's typically considered as a full-timer. So I am 0.4, which is like yeah, it's not 1/4, it's less than half, a little bit less than half of a full-timer.
Got it. Okay, that makes sense. All right, so I have one last question for you. It's 2:30, so if anyone has questions, please type it in the chat. And then we will get to that right after this question is answered. So a lot of pre-med students stress about a lot of things and try their best to manage with the time that they have. So what is your opinion on what pre-med students should stress about or should kind of prioritize and focus on? And then what should they maybe not stress about as much as they currently do? So what should they prioritize and what should people say is a priority but shouldn't be that prioritized? If that makes sense.
Priorities on getting into medicine as a goal, or
Um, as a step for getting into medicine.
as a step? Okay. I think, of course, you have to get your scores, right? Like, when you're working on your scores, you get your scores. Also building up some projects that are interesting to you. I think if you are able to show that you are just doing it just because medicine will fetch you a lot of money, and then you're not just doing it for the sake of salary, or as just another occupation. um and Yeah, yeah, that part, yes, I do. I'm happy with the salary I get for 1.5 days of week. I have to share that with you. So yes, it is a good occupation as such, with good salary, but um that should not be the intention to get into medicine. So if you can prioritize or on activities that will lead you to show that interest, that you are coming into this into this field with a passion, with with being a scientist, or being whatever it is, like caring for people. So whatever your call is as a person, if you can you know align your activities towards that. Like, let's say if you are into research, if you can do some activities in that order, and do some projects, then that'll help you move towards your goal. Or if you had some community interest, then like do that. So the focus, I think by now you guys would know your focuses, right? Like focus. Um, so if you know some of that, like what you want to do, so if you can just do those things, then I think it'll be an easy way to get into medicine.
So I guess kind of just pursue your own passions and interests, and the story kind of writes itself. And as long as your passions and everything comes through, you should get into medical school. So now the other question was, what are some things that you think medical students stress too much about, but it shouldn't be that stressful, or they shouldn't pay as much attention to?
Um,
Or I
I
guess if
don't
there's
know.
not
I
really a
feel
good
like,
answer for that, then we can move on to the other questions.
yeah. So I don't know. I feel like the person, okay, I have seen, I've come across a couple, like whoever I come across with interest in medicine, they're usually driven, they know what they're doing. Most of you guys, just shadow and try to understand and like get their path in one way, except like one or two, they just really don't know. And then they're like, yeah, I want to do this, I want to do that. I think that's lack of focus is what probably something I would discourage. And I don't know if that's a good answer or not. Um, I think, yeah, if you are interested, try to analyze that, talk to people, and then get the clarity first. I think if you have a good clarity of what you want in this field, and then try to work towards that, and then like not do like, oh, just because Sham is going and like you know rounding with all these doctors like shadowing, then I should be doing that too. Or just because this John is going and doing an EMS certificate, that's a good pathway. I mean, I see that too. And then there are people who are volunteering in the hospital. So you don't have to do all of that to get in. Like you just have to focus on one specific thing, and then uh, and do it with your full heart, and put your 100%. Did I
Yeah,
make
I
sense?
think that's great advice. I kind of guess kind of write your own story, um, and follow your actual passions rather than trying to do what other people do. Got it. Thank you so much. So we'll now go in order of the questions that are in the chat, and I'll just read it out so it's on recording. So the first question is, what are some ways that you've seen the field of medicine change since you came to South Carolina in 2003? Whether the philosophies of new doctors, hospital administrators, or dealing with the insurance, etc.
Oh, so the field of medicine has changed a lot in the last 20 years, right? Oh my God, yes. So there is, it's just amazing. I can't, like 20 years ago, we still, I mean, it's about the same. We still had the EMR. We still had to do some charting in the in a hard, like there was like medical records, like you will write some notes and then you'll put orders. So from starting from there, the transformation has been like amazing. um and then we have evolved to just do everything in the computer, right? So but there have been like several protocols that have come into play which have been great. Like some of them are able to be measured, so you can have like measured outcome because it's all in computers, and there's like this big data, and then there's like a lot of IT play that has come now. So this is probably one of the most challenging time to practice medicine, but at the same time, for the future of medicine, I think there is also hope going forward with more of AI and like IT getting involved in this field. So there has been the autonomy of physicians have changed a lot. Now there's like more corporates and like more administrative say right now. So we are all those things are challenging, honestly, to be able to practice the way we want. So I think we are in the transformational phase right now. But I mean, if you, it's going to happen. Like each and every time, you will have some sort of challenge. So that is how we'll come up with solutions. So it's there, and it's we I think as medical community we are trying to find solution for that. Um, and most of the times we are able to get that successfully done. I do not know if I am being very broad in what I answered.
You're saying like fighting back the corporate system that's kind of reducing your autonomy. Y'all are fighting for getting back that autonomy that has been lost over the years.
Right. Yes, I didn't want to use the word fight, but you did say it right. But we are, that's honestly right. I think we have to set our boundaries. We cannot keep being like pawns. And that's what we are trying to establish more so than like fighting back. Like we won't do that. But we are saying like, here, this is my fort, this is my shield, and this is where we stop. So if they are pushing the boundary, then we are pushing back. So I'm not saying like, okay, I won't do this. I'm just saying I can only do this. So, so,
Got it. I think that's a good answer. I think you answered that pretty well. All right, so now Isabella has asked a really good question. So you mentioned there are some patients that kind of lack the support system, maybe income or environment, to help with their wound healing. So are there any resources that the hospital or any other third-party organization provides to help these patients, or what do you do for these patients?
um, it's a really good question, Isabella. It's a challenge still. What I do personally, I try to like have I mean, there are organizations to start off. Let me say that, like, there is something called Care and they would be able to help with that if they get approved. But I've not had one single patient that has been successful through that program because it's a process. Like you have to download a form, you have to fill that form and send it, and most of my patients don't do that. So in our hospital, it's been a challenge too in clinics. What I do, I try to gather the surplus that other patients get, like those with insurance, and then I store it, and then we just give it to some of those who cannot. um, there are issues with compliance with that, but I just tell them that you can get it from my trunk in the parking lot than from my office. So you can read between these lines what I said. But that's how we are dealing with it. But there's also complex care case management in the hospital. They try to help with other things like transportation, or there is a family access program, or sorry, financial assistance program, FAP. And they try to see if their income is below certain level, they will get into that, and then they will try to help through that hospital insurance program that's called FAP. So that's another avenue for them to do. So these are there, but still, like I said, like there's a majority of patients who cannot just afford any of this. There is a hole which is not being addressed with any of these tools in place.
All right, and then the next question is, what are some things that you recommend doing to prevent or fight burnout?
Okay, so Uh, I'm actually a wellness champion with our ACP, which is American College of Physicians for the South Carolina chapter. So I have a thing called 10 Commandments. So I go, do you want me to read that? I'm sure I have it. So I have to see where my 10 commands is. Hold on just a minute. Um, so it's basically, if I cannot find it, I'll just say what I try to do. It's, um, you have to set boundaries. You have to do workouts on a regular basis, mindfulness in your at work. Um, you have to take some breaths in between, like walk back and forth, just clear your head, take some breaks. Um, then um, like identifying that you start, like when you start complaining about things, like when you start saying the world is a doom, like nothing can come out, then that's when you realize like you are reaching that point of burnout. So identifying that, and then like putting things in place. Like the first thing I do is, as soon as I get up, I do stretches. I try to do meditation as much as possible, especially on the days that I go to work. And then get this mindfulness, deep breathing exercises, and then clear my head. Um, and also saying something like gratitude, like what I'm thankful for, those things, like write down those things, three things that you are grateful for that particular day. So all those things, like bringing that positive energy. Um, and This is a high intense job. It's like athlete. It's like working, like it's your brain function is like the athletes that are high performance athletes. You have to remember that. So you cannot be ignoring your body, because your body is going to reflect on your mind. So keep you keep your body well. Like do some activities, physical activities, do some social activities to feed what is nurturing your soul. So do something that is passionate for you. If you are into any sport that you're passionate about, take that on. If you're into music, do that. Like I'm into dance, so I do that religiously. No matter what, I have to go to my class. So take on some hobby or sport so that you are not getting burnt out.
Do you think that's something that we should structure into our lives or kind of just do when we get time? Because I know a lot of people try to structure it and then they feel really bad when they're unable to, I guess, like, for example, work out for a day or something like that.
Yeah, yeah. There's something called habit stacking. So just add one thing to your routine. So you're getting up and then like you're brushing your teeth. You just want add one more thing. You just take a notebook next to where you keep it, wherever it is, like where next to your bathroom, or wherever you come next. Like if you're going to have coffee, then you can keep a notebook there and then just write down your prayer of gratitude, things like that. And then slowly, like that'll become your habit, and then like stack something more, just like 5 minutes of meditation. So something obviously the every day is not going to be the same. So you may be like thrown off, and your routine may become, you know, it may get affected by something or disrupted. Then what I do, like when I am in the car, I do my mindfulness. So, add something that like, the box breathing, like 1, 2, 3, 4, 5, 6, and then hold our breath and like down. So all those things. So just don't sweat about it. Don't, don't stress out of not doing all this, but then like do small changes, few things at one thing at a time.
Yeah, I've never heard of habit stacking before. I think that's a great idea. So I think that's definitely something I will be looking into. Um, Then the next question is it's by Mira, and it's how do you determine the best treatment plan for wounds? And are there new technologies that have impacted your field?
Yeah. So, each patient will get a treatment plan, like depending upon what their wound is, like the etiology of the wound is. So then we go into that, and then we also have a pledge for patients to sign and say, like, I'm going to do my part, and then I'm going to do this part. So we do that, and then we'll go over the treatment plan with them. And the treatment plan usually is like incorporating nutrition, coming to the appointments on a regular basis, and following certain things that we recommend them to do, and so forth. Um, as far as technology goes, there are like so many things that have come in now. Like there's a big breakthrough with skin substitutes. So there are patients previously going into surgery and then getting a skin graft that has been replaced now. Like we do the debridement at bedside in the wound center, and then we have like several products like human placenta. They're like donated cadaveric products. There are like skin from a cadaver that has been donated that acts like a skin substitute. So we put it on as a graft. So there are so many products out there that has revolutionized. And negative pressure wound therapy is another revolution where like you apply a vacuum, so forth, so-called vacuum into the wound, and then like suck the tissues together, which will allow blood circulation to improve and also the tissues to approximate and then promote wound healing. That has revolutionized. And there are like ultrasound debridement tools that have revolutionized. So there's a lot coming in this field which are like exciting.
So when you're determining the best treatment for a wound, what are some of the factors of the wound that you look at? Is it like how big the wound is, the depth, if there's tunneling, circulation? Like what are all the things that you look at?
So when I see a wound, first thing like I look at is like how, yeah, of course, like education, I mean, the circulation and all that, like a physical aspect. The most important thing is like the patient. For me, that's like one important thing that, like, as I said earlier, um, can I educate the patient? Can they participate in their wound care? Will they follow what I say? So those are my most important things. But aside from that, like for the physical aspect of the wound, um, circulation is important. Or saying like tunneling or depth is important. So if a wound looks black and necrotic, and then there's a big tunnel, like a deep, it's going to the bone. I know it's not going to heal well. It's going to take some time. Sometimes it may be also leading to loss of a body part. Um, so sharing that with the patient is another feature, another important aspect. Like communicating is also important in that encounter. Circulation is a huge aspect because if you don't give blood or oxygen to that area, no matter what you do, it's not going to heal. So that's very, very, very important. So,
Great. And then moving on to our last question. It's by Boris. And the question is, what is the biggest factor in your decision to specialize in wound care, and how was it different from what you expected?
so yeah, as I said earlier, I just touched upon that subject very briefly and moved on. So as a hospitalist, we get to see vital signs, we get to see the medications given and like other things that patients, or I see a patient, he's most of the time in the bed or sitting, but then like I'm not examining their bottom or their back on a regular basis, just listening to their heart, lungs, checking their bellies. So that's a quick in and out, right? Like, I mean, whether it's quick or not, I'm not focused on their back. So I ended up finding a lot of patients with wounds, um, because I don't know, I was just inclined towards wounds somehow. Even when I was in med school, I guess I had I saw a lot of wounds in India, and then I was good in debridement even at that time. So I realized, because if you think about it, in your body, the biggest organ is skin. It's huge, right? Like it's covering the whole body. So skin is such an important organ we tend to ignore. So I've seen patients going to from just coming without any wounds to stage 4 bed sore, which is like going to the bone and like becoming infected and dying from it. So because nobody paid attention to that. So that was my biggest concern. Like how can I prevent this? So I came up with the plan for hospital to reduce these pressure injuries. And then they said, like, okay, you can become a champion for pressure injury. And then I said, look, I don't have any knowledge in this field. So when that, right then they had called for hospitals to come and help in the wound center. I said, like, okay, I'm going to go there. And then like when I started this, I just loved it. I just enjoyed it so much that I just switched to wound center, being a wound clinician.
Got it. And we got one more question, and then we'll jump right into the case. It's by Isabella, and her question is, what made you want to practice here, and how difficult was it to pursue medicine as someone from abroad?
Can you say the first part of the question?
Yes, what made you want to practice being a physician here, and then how difficult was it to practice from being abroad?
Yeah, okay. Yeah, so we when you're in med school in India, like I think people don't realize how fortunate you guys are. I mean, you guys. I think you probably know how fortunate you are, um, but people in the U.S. generally are blessed to have all the facilities and what we read in your books, like you are able to practice. Majority of that, like in med school when we were in India, like we would see tons and tons of clinical cases. Like there's no dearth for cases that are described in textbook. Whatever signs and symptoms that are described in textbook for a disease, you will see, because they're like, there's no, I mean, India is number one now in population, so you'll see a lot of patients there. So there's no question about that. But how do we treat? Like we didn't have that facility there. So and then like they'll say like, oh, we do this, this, and this, but that was not followed there. So I think there was a that angst for for me as a doctor to practice what I learned, right? So when I went to a hospital who had a physician return from the US, and he was doing all kinds of stuff that was described in books, like that was just fascinating for me. So that was attractive for me to come here and practice medicine. And yeah, I really enjoy practicing medicine here. Of course, like we have challenges here as well. As a physician from a foreign country, my biggest challenge was language. I think I had, like, especially coming to the South, I couldn't understand the slang. So I would watch a lot of TV shows. And even then, like, I had struggle with understanding patients at first. But with time, I learned that, and I would not understand some of those jokes, the local jokes. I wouldn't get it. Even now, I don't get some of those. But I don't think that would prevent you to become from being successful. If you care for a patient, the caring aspect is universal language. If you show that you care, if you show that you have knowledge, and then you do a good job, regardless of where you're from, I think it won't be a problem. And another challenge was like being away from family. Like I had a lot of struggle taking care of my young children without support of family. So that's a totally different topic. But that was a huge challenge that I had to deal with. Um, but yep. Uh, But I'm very happy that I am here in this country and able to practice what we read and what we learn, and you know all tools that are available when you want it. It's at your disposal.
All right, well, thank you so much for sharing your experiences as a wound care specialist, but also everything that you've learned since you've gotten here and been able to practice. We'll jump right into the case study. I'll share my screen, and it shouldn't take the full 30 minutes. I know I mentioned that it would be optional in the meeting that I sent out, or in the email that I sent out. Like I said, it shouldn't take too long, and it'll just kind of give you a good idea of what Dr. Ramasamy does. So if you just want to tell me when to move on to the next slide, I could just do that.
Okay. So the next one, please. So this is a case. I'm just going to ask you guys and like get in. Like this is not going to be just me talking. So I do not know as an undergrad what your level of knowledge you would have in seeing these cases, but let's see. Let's try it. Okay. So this is first case one is on the top left. That's a wound this patient came with. 57-year-old lady with a type 1 diabetes, which is like insulin requiring diabetes. She had history of heart disease, poorly controlled diabetes. She had peripheral vascular disease, which means like poor circulation. She also had nerve issues. And then she had this wound for several years. And she was seen by orthopedic surgeons, vascular surgeons, and then they came to me saying that, okay, they are not able to heal it. She's had like bone infection in the past that got treated. She had surgery, but it just wouldn't heal. So they sent her to me. So I was taking care of that patient, and on the top left, right? This was like the big end of last year or so. Can you guys say why this happens in a diabetic? Can anyone say that? And most common wounds in diabetics are the feet. That's a clue.
Is it, at least for feet, isn't it usually like their limbs will go numb, especially their feet, and they could step on something and then they could get an infection from that?
Absolutely, bang. That's you're right on, uh, spot on. So it's exactly like they have neuropathy, nerve issues, so they are not able to feel what they are stepping on. So they step on that, and then they don't realize that they have a wound until they are seeing it, right? Like a lot of people don't look at their feet every day. So they just go on, and then suddenly, like, they come up with this big wound with like big hole, and then there's like bone sticking out. They won't still have pain at all. So that's most important thing in diabetics. Like they get wounds in their legs because of that. So it's important as a primary care doctors to check their legs, their feet periodically, and make sure if they have nerve issues in their feet, address it appropriately with medications and appropriate footwear. So insurance actually covers for this type of the footwear so that they are protected. We have to educate the patient about footwear, and then like having them look at their feet every day and make sure they are wearing a footwear wherever they go. So very good job. And there's also another reason why their wounds don't heal. Can anybody state why?
Do they have poor circulation as well?
Yep, exactly. So diabetes affects the circulation. So because not just like the big blood vessels, they're small branches. That's the ominous thing about diabetics because they affect the small blood vessels. So even if you open the big pipe, if the tree branches, if they are affected and those cannot be stented or have a balloon and dilated, then there's no way you can improve the circulation, right? So it's a big problem with diabetics, like when they have this disease of the small blood vessels, and that's another reason. Um, And they are also, because of the nerves that are affected, the bones tend to move because the bones are not kept in place by the muscles. The muscles lose tone because the nerves are not keeping them in place. So that's what happened in her. You see how her toe is turned that way um, towards her other toes. They crowd and they turn and their pressure point change. And so there are more pressure on certain areas of their feet and they end up with wounds like that. So the bottom left is a wound she came with, and she didn't tell me about this. This was like several months into knowing her. I saw like, hey, what is this? And she's like, I don't know, doc. It started coming up, and I had a mole previously, and then it started growing, and then it starts bleeding. It's crazy bleeding. I just used the dressing material that you give, and that's all she said. What should I do about this? Is it something of concern, or should I say, yeah, you're doing a good job? Um, Continue to do the same dressing. Don't do anything about it. It's going to heal. What am I supposed to say here? Anyone? So I gave a clue. It was previously a mole, and then it started growing. Does that give you any clue?
Is it possibly cancerous?
Yep, absolutely. You're right. Next slide, please. So yeah, I don't know how much you can read this and understand, but then it's a malignant melanoma that was invasive. So I freaked out when she said that, and like I couldn't share my anxiety with her. I said like, well, I have to refer you to a dermatology urgently. And I referred. She comes back 2 weeks later. She had not seen the dermatology. I'm freaking out again. Typically, I go on to do biopsies, but I knew it's probably melanoma. Melanoma, we don't tend to do biopsy because there is a chance that there are like two schools of thought that, one should not do biopsy. They're just going to do an excision, like take the whole thing out. Because when you do biopsy, there is a chance that you can disrupt the blood vessels and it can tend to go and spread into the blood. So I didn't want to biopsy it. I wanted the dermatologist to look at it right away, but she didn't understand what I was trying to say. I did tell her I'm worried about cancer. I told her, she said like, oh, I'm going to ask my cousin who went to this dermatologist. I'm going to go to them and then come back. So 2 weeks later, again, she had not. So by the time it was more than a month or two, I think, I was like, okay, fine, enough. I'm going to call somebody and then like get her urgently to plastics. So it turned out in that time period, it had gone to one of the nodes in her leg. So it's become a big issue. So yeah, we don't play with this. So this is something, a teaching moment for you guys too. Like when you see as either medical or non-medical, you have to remember that if there is a mole and if it's going to change in character, you have to seek attention right away. And another teaching point for me was like, even if a patient does not talk about any other lesion, you're not just sticking to that one particular wound. You are seeing that patient as a whole. So pay attention to other areas in their body too. So let's go to the next one. Okay, so this is another case. This is a 60-year-old diabetic lady, came with this foot wound that was present for several months. So that's the top left one, right? So why would she have a wound on the top? Can anybody say? We talked about the diabetes aspect and neuropathy and all that. Does anybody see anything different with the structure of the foot or shape of the foot? Is anything wrong with it, or is it perfectly fine?
The arch of her foot is angled super, super weirdly, so it's making the top of her foot stick out more, maybe?
Yes, absolutely. You're right. So it's so high arching, and then the top is sticking out, and so the shoes over that, like whatever she's wearing, it's rubbing and causing a wound on the top and not at the bottom. So this can happen again with diabetics with nerve issues. Then different types of nerves that are involved, they can have different types of structure. So we have to understand that. So it was important. And in her case, she had like ailing parents. She was the only caregiver for her parents. She would not go for getting an appropriate shoe. So it was a very hard wound to heal. So she would like have a small, like it became very tiny little, but it'll keep like opening up. And then the bottom left is a wound she had on her right breast. And she said like, oh, I had this wound and it healed up and now it's open. So what should be my next step? Any guess? Anybody?
I guess my guess would be like to find what was causing the wound.
Yeah, exactly. Yeah. So why would you have a wound on the breast, right? Like, I mean, if you're diabetic, yes, you can have it on the foot. If you had any issues with nimbus and fingers, and if you're a smoker, or if you had kidney disease or diabetic, your fingers can get affected. You can have wounds on the fingers. Now, like, why do they have it on the breast? Like, is there a reason for that? So that's exactly my question is like, I cannot think of anything that can cause a wound on the breast. But she did report like she used to be a surfer and she used to spend a lot of time on the outside, exposed to exposed to sun as in young age. So that was a clue for me. Can you guys guess what could it be now?
Was it a mole before that opened up?
It's actually cancer. Yeah, it's an oh. Can you go to the next slide? Yeah. So this one, again, I had to, convince her for several months. It was like there. Thankfully, it's a basal cell carcinoma. It's a skin cancer, which doesn't, it's not aggressive like melanoma. But you see in that pathology, it says lesion extends to the base of the shave. So I wanted to do the biopsy on it. She said, like, doc, it's working. Whatever you were giving the dressing, it's working, doc. I don't want to do anything about it. So it took a couple of 2 or 3 visits for me to convince her. Well, I sent her to a derm. They said, like, oh, whatever your wound doc is doing, it's fine. Just continue that. So the dermatologist did not do a biopsy. Primary care sent her to a mammogram, and then they did a mammogram. It was fine, no cancer inside. Then I finally convinced her to get a biopsy from me. I said, like, well, no, I'm not I'm worried. I want to do a biopsy, and it turned out to be this. So that's the teaching moment for me is like if you are with your physician hat, like you have given it to other people, like other physicians. Yeah, you appropriately delegated or referred, but you cannot just rely upon referrals. As a physician, if you have high concern, like highly concerned about something, you go after it. If your referral person did not give you the answer that you were expecting, then refer, and you are not equipped to do your own biopsy, then refer to another person. So these are two cases that are really like, stand out. Like I have several other ones, but these are two I want to point out as people who are inclined to become doctors, to never give up. They could be there, and these are the wounds that are going to be there. They're not going to seek attention because they are not painful, right? Like that's one big thing with patients. Like if they have no pain, they're not going to pay attention to that. In both of these, what are the common factors? Both of these situations, both females, both diabetics, and what are the things that I said about social factors?
Uncontrolled blood sugars.
Uncontrolled blood sugars, yes. But also I said something about their social situation. So remember, like I talked about like the second one being caregiver and, taking care of her family members, her ailing parents. Yeah, she was so focused on them, she didn't care about herself. So she was neglecting her own physical ailment. So that's a big, big, big determinant, right? And one of the previous one, I said like she was going to ask her cousin and go to this dermatologist, and she did not. So, she just neglected her own care, even though she promised me she is going to do that. So that's very, very common thing you will see when you come into medicine. Even there are a lot of things that you cannot control. You will prescribe whatever you prescribe, cannot only if you had like 1/10 of it being carried out, that's a big success. So understand that there are so many other factors in your practice that is going to determine the success stories that you can share with others. So next slide. So yeah, this is what I want to highlight today before we end our discussion. Social determinants of health. And thankfully, our healthcare is paying a lot of attention now, and government is paying a lot of attention to this. So these are non-medical factors that are affecting the health outcomes. So according to CDC, these include the conditions in which people are born, grow, work, live, and age. They also include the broader forces and systems that shape everyday life condition. So it could be like education, access to their like transportation, right? How good, how food insecurity, like you can prescribe a great nutritional plan. Can they buy all that, right? Economic stability. Do they have the ability to provide all the, to have the footwear that you are prescribing? You buy the dressing material that you are prescribing. Social and community context, like do they have enough support as a family member? Let's say they have a wound in the back and they cannot get to it. Like, is there somebody who can apply to that, right? And then neighborhood and built environment, like do they have a good social and neighborhood that are easy, that have ability to get to this hospital right away? So there are so many things that are important factors in patient care. So if as undergrads, I want you to remember these, and then if you have any interest in like coming up with any solution in any of these topics, these are great topics that you can focus on and then like do some projects on that. And that may help you get into to medical school as well. This is hot topic. All right. I hope you guys enjoyed. That's all. That is my end of case discussion.
All right, Dr. Ramasamy, well, thank you so much for sharing your experience and knowledge once again. If anyone has any last minute questions, feel free to ask, but that's the end of our webinar. If you have any feedback on something you'd like to hear in the future, or would like any program changes or schedule changes or anything, just let me know. You can type it in the chat. You can also send it to my email. But if not, thank you so much for attending, and y'all have a great rest of your weekend.
All right. Thank you, Sham and others. Good luck with your journey in pursuing medicine. I think it'll be very rewarding. I can say that much. Thank you.
Thank you so much.
You're welcome. All right, Sham.
All right. Well, thank you so much for spending your time on a Sunday. This was great.
Yeah.
I found it really informative for me personally, and I'll put this recording up and share it with you if you want to show anybody else as well.
Okay. Sounds
All
good.
right.
All right. All right. Take care. Bye-bye.
Thank you so much. Bye.
Bye.